Good afternoon, good evening to everyone. I think we're all joining from different time zones. So thank you to all for joining us for this learning lab. My name is Michelle Remes. I'm an assistant professor in health economics at the London School of Hygiene and Tropical Medicine, and I'm a member of STRIVE. For those of you who don't know STRIVE, just a very brief intro. STRIVE is a research program consortium funded by UK Aid that was launched in 2011 to contribute to building the evidence base and enhance our understanding of the structural drivers of HIV, and to develop methodological approaches to better research, measure, and evaluate the drivers, as well as the interventions to address them. So initially, our focus was on sort of upstream factors like gender inequality and violence, poor livelihood options, alcohol availability and drinking norms, and stigma and criminalization. In addition to those, we're also now looking a bit more at transactional effects and development synergies and how you could co-finance such interventions. So the partners of the consortium are the London School of Hygiene and Tropical Medicine, the National Institute for Medical Research, the Mwanza Center in particular, VITS Reproductive Health and HIV Institute in South Africa, the Karnataka Health Promotion Trust in India, and the ICW, International Center for Research on Women in DC and in India. So for more information, please do have a look at our website if you haven't yet, and also if you're interested to sign up for our newsletter, now is the time, because there's some hopefully interesting outputs around the corner as we work on synthesizing the work we've been doing and others have been doing in this area over the past 5+ years. So that was for STRIVE. Back to today's exciting learning lab, which relates specifically to the poverty and poor livelihood options side of things, and how essentially these poor livelihood options can impact negatively on the effectiveness of biomedical interventions for HIV, or more positively looking at it, how interventions to address economic barriers could improve HIV outcomes. So I'm very pleased to introduce today's speaker, Dr. Sandra McCoy, whom I've had the privilege and pleasure to work with. She is an assistant professor in the Division of Epidemiology at the University of California, Berkeley School of Public Health. Together with collaborators in sub-Saharan Africa, Mexico, and the United States, her research focuses on how social and economic factors influence disease transmission and sexual and reproductive health outcomes. Most of Dr. McCoy's research projects culminate in the design and evaluation of new interventions intended to positively change health behavior, such as increasing adherence to ART or encouraging people to engage in health screenings, such as HIV testing. And through a diverse array of approaches, her goal is to identify innovative, cost-effective, and scalable interventions to overcome global health challenges. Now, today she's going to be talking to us about mitigating the effect of food insecurity on adherence to HIV treatment in Tanzania, and answering the question of whether conditional cash and food transfers are effective strategies.
Thank you so much for that nice introduction, Michelle. I am delighted to be here today to present to all of you, and good morning and good afternoon and good evening to all of you. I know everyone is all around the world. And I would especially like to thank the STRIVE Consortium for inviting me to give this learning lab today. And I'd also just like to acknowledge my collaborators on this project, particularly colleagues at UC Berkeley, the Tanzanian Ministry of Health, Community Development, Gender, Elderly, and Children, and the London School of Hygiene and Tropical Medicine. And the work that I'll present for the next 20 minutes or so was funded by the National Institute of Health and by the PEPFAR Food and Nutrition Technical Working Group. So I'm very grateful to those sponsors for supporting this work. Okay, so to get started, I'm sure most of you know that economic factors are increasingly recognized as barriers to antiretroviral therapy, adherence, and retention and care. And I'm going to refer to antiretroviral therapy in this presentation as ART. We're going to focus today on food insecurity, which is one dimension of economic well-being that overlaps with the HIV epidemic. And food insecurity is defined as the lack of secure access to sufficient, safe, and nutritious food for normal growth and development and an active and healthy life. Now, this is an incredible problem in sub-Saharan Africa, where there are 22 million people who are undernourished, which is one indicator of food insecurity, and this represents 23% of the population. So numerous studies, as shown on this forest plot, have shown that food insecurity and or hunger is consistently associated with poor adherence to ART. food insecurity is hypothesized to impede access to HIV-related services through multiple mechanisms, including forcing people to choose between food and care, and also exacerbating the side effects associated with taking ART without food. Now, surprisingly, after you exclude the studies that have looked at micronutrient supplementation alone, there have actually been very few intervention studies of food aid programs targeted to people living with HIV infection in low and middle income countries. And those few studies are shown here on the slide under the first bullet. Although the majority of these studies have demonstrated some positive effects on ART adherence, the lack of rigorous evidence really limits our conclusions about the effectiveness of food aid. And this includes studies that are conducted without comparison groups, those that are not randomized, and those with very small sample sizes. At the same time, some people have hypothesized that cash could be as effective or more effective than food aid for improving ART adherence and retention and care. Among development economists, there's a long-standing debate about cash versus in-kind assistance. We know that cash grants are as good or better than many traditional forms of aid for poverty alleviation. And we also know that cash gives beneficiaries the freedom of choice, is cheaper to distribute, particularly nowadays through mobile money services. And in some settings, cash may actually be preferred by beneficiaries over food assistance. Now, among studies that have been conducted among people living with HIV infection, several studies have demonstrated that cash transfers can indeed improve ART adherence. But all of these studies have been conducted in high-income countries with no evidence yet from sub-Saharan Africa. So to address these gaps, we conducted a study to evaluate the effectiveness of short-term cash and food assistance to mitigate food insecurity and improve adherence to antiretroviral therapy and retention and care among people living with HIV infection in Tanzania. So this study was pre-registered at clinicaltrials.gov, and the protocol was published last year in BMC Infectious Diseases. So the study was conducted at 3 primary care clinics in Shinyanga, which is a resource-constrained region in Tanzania. Participants were eligible for the study if they were at least 18 years of age, were living with HIV infection, were food insecure, ascertained by the household hunger scale, and if they had initiated ART 90 days or less before enrollment. And patients who were severely malnourished were excluded from the study. So we conducted a 3-arm randomized trial to examine the comparative effectiveness of short-term cash and food assistance. And I'll walk you through the intervention groups now. So participants in the comparison arm, shown on the very left-hand side of your slide, received the standard HIV primary care services, including nutrition assessment and counseling, or NAC. Participants in the NAC plus cash transfer arm received the standard of care services plus the opportunity to receive a monthly cash transfer of 22,500 Tanzanian shillings, or approximately $11 US. This value was selected to prevent undue coercion and also to be consistent with the Tanzania Social Action Fund, or TASIF, which is a government-run anti-poverty program. Cash was transferred to participants primarily through mobile money transfer services. Participants in the NAC plus food assistance arm, shown on the very right-hand side of your slide, received the standard of care services plus the opportunity to receive a monthly food basket. The food basket was equivalently valued as the cash transfer and was intended to supplement but not replace the household food supply. Now, participants in both the cash and food transfer groups were eligible to receive assistance for up to 6 consecutive months. But support was conditional on attending scheduled visits, which were typically every 30 or 60 days, depending on how the provider scheduled the person's next appointment. The primary outcome was ART adherence at 6 months, which was the end of the cash or food transfer period. And we measured ART adherence with the medication possession ratio, or MPR, which is the proportion of days that an individual is in possession of at least 1 dose of ART. And we computed MPR at an adherence threshold of 95%. But we also had several secondary outcomes. These included MPR 95 at 12 months, as well as MPR on a continuous scale at 6 and 12 months. We also measured retention and care in order to understand whether the intervention improved engagement with clinic services. We assessed loss to follow-up, defined as 90 days since the last scheduled visit, and appointment attendance, defined as the proportion of scheduled visits that were attended during the 0 to 6 and 0 to 12-month observation periods. So the trial profile is shown on this slide. From December 2013 to July 2015, we recruited 805 participants and randomly allocated them to the 3 study arms in a 1:3:3 ratio. 98% of those who were eligible agreed to participate in the study. After we excluded 5 people, the ITT analysis on the primary outcome included 800 participants. This included 112 participants in the comparison arm, 346 in the cash transfer arm, and 342 in the food transfer arm. The characteristics of the study participants at baseline are shown on this slide. At enrollment, the median age was 35 years, 63% of participants were female, and the median CD4 count was 200 cells per microliter. This slide shows participant characteristics stratified by study group. We find that the participant characteristics were balanced between the 3 study groups, with the exception of language, occupation, and WHO clinical stage, which are highlighted here in bold. During the study period, there were no adverse events and there were no major implementation issues. We distributed more than 1,700 cash transfers and nearly 1,500 food baskets. Both cash and food recipients reported that the transfers were predominantly used to supplement the household food supply, either through purchasing food or consuming the contents of the food basket. And when we asked people at 6 months about their preferences, participants preferred cash regardless of study arm. The results of the Intenttotreat analysis on the primary outcome are shown on this slide. So let me walk you through how this looks. The first 4 columns are the percent of patients overall and within each group for each of the outcomes. And the last 3 columns present the between-group differences. So these are risk differences. The data shown here are unadjusted, but the adjusted results did not significantly differ. So let's first focus on the cash group. At 6 months, adherence was significantly greater in the cash transfer group versus the comparison group. For example, 85% of patients in the cash transfer group achieved MPR 95 compared to 63% in the comparison group, and this was a 21.6 percentage point difference. Now let's take a look at the food group. So MPR 95% and MPR were both significantly greater in the food assistance group when compared to the comparison group. When we directly compared food and cash, there were no statistically significant differences between cash and food transfers on 6-month adherence. Now let's take a look at 12 months. That is shown on the bottom half of this table. So at 12 months, 6 months after the intervention period had ended, both MPR 95% and MPR was significantly greater in the cash group compared to the NAC-only group. Now in the food group, MPR, but not MPR 95, was significantly higher than the NAC-only group. And when directly compared, both NPR 95 and MPR was significantly higher in the cash group versus the food group. Now let's take a look at retention and care. This includes loss to follow-up and appointment attendance. So the top half of this table displays the outcomes at 6 months, and the bottom half of the table displays the outcomes at 12 months. So let's first take a look at the 6-month outcomes. So compared to the NAC-only group, we observed significantly higher appointment attendance at 6 months among those who were randomized to either NAC plus cash or NAC plus food. NAC plus cash, for example, was associated with a 13.5 percentage point increase in appointment attendance at 6 months, and NAC plus food was associated with an 11.8 percentage point increase in appointment attendance. In addition, loss to follow-up was significantly less likely in the 2 intervention groups at 6 months. You can see that 10.9% of participants were lost to follow-up by 6 months in the NAC-only group, compared with 0.9% in the cash group and 1.5% in the food group. When directly compared, there was no difference between cash and food at 6 months for these retention outcomes. Now let's focus on the intervention's effects on retention and care at 12 months, 6 months after the intervention has ended. We find that at 12 months, appointment attendance remained significantly higher in the NAC plus cash and the NAC plus food groups compared to the NAC-only group. The effect of cash but not food on loss to follow-up persisted at 12 months, with no statistical difference between cash and food. So this graph shows a time-to-event analysis of loss to follow-up. It's a different way of looking at the data that we just looked at on the previous chart, and we're instead looking at the timing of loss to follow-up instead of just loss to follow-up overall. So the y-axis here shows you the proportion of patients who remained in care over time, and the x-axis displays the number of months since study enrollment. And keep in mind that people at the beginning of the study had to have started ART within the last 90 days. So the months since enrollment roughly corresponds with time on ART. So you can see here that the effect of NAC plus cash and NAC plus food on preventing loss to follow-up was concentrated in the first 3 months of the program when we observed quite a few people who drop out of care. And even though the effects are observed very early, the proportion who are retained in care remains higher in both of the intervention groups, even after the intervention had ended at 6 months. When we look at MPR 95 by quarter, we see something similar. So you can see here that the intervention's effect on adherence was concentrated in the first 3 months of the program, which are those first 3 bars on the left-hand side. And after that time, MPR 95% gradually becomes similar in all the groups, especially once the transfer program had ended at 6 months. So in other words, although the interventions have significant effects on MPR 95% at 6 and 12 months, when we restrict the data to these 3-month periods, we can see that the effects are observed really early. So we also did an ancillary qualitative study to understand how people use the food and cash transfers, and I've included here a few quotations from cash recipients. People reported using the cash transfers to purchase livestock, to purchase food, and to pay school fees. So you can see the first quotation here. A person bought a goat with the hope that the goat can bear and the son can sell it in the future to get money for studies. In the second quotation, a person said that the cash was used for buying food and also to pay school fees. And the last person again said that the cash was used to help buy food for the family, including 2 children. And this was something that we heard very consistently in the qualitative data, that the cash transfers were predominantly used for food. We also conducted a quantitative survey with all of the cash transfer recipients, and these qualitative insights hold up in the quantitative data as well, where we see increased expenditures on food among cash transfer recipients. So the qualitative work here, which I should mention was led by Dr. Nancy Seisky, she was an Epi graduate student at the time, revealed that there were 3 primary pathways through which the cash and food transfers increased adherence to ART. Incentives increased or addressed the competing needs and offset opportunity costs. So they allowed it so people had transportation, had money for transportation to the clinic, and it also, addressed other needs that they might have in terms of missing work for the day to come to the clinic. The incentives also increased motivation via a price effect, essentially by making clinic attendance more attractive. And we also heard from numerous participants that the cash and food transfers alleviated stress and anxiety, and I think that this is an important pathway in particular, supported by both conceptual models and a growing body of empirical data suggesting the importance of mental health and in HIV care. So this study has several important limitations. First, we did not measure viral load, which is the ultimate goal of HIV treatment, but MPR is highly correlated with short-term viral suppression. Second, there is the possibility of missing data because we relied on paper-based medical records. But we do know that missing data was not differential by study arm, and our hypothesis is that missing data would likely result in underestimates of adherence and retention because we would be missing pharmacy dispensing data and visit dates. And finally, this study was powered to determine whether cash assistance was non-inferior to food assistance, but we did not have the power to detect small differences between the 2 interventions. So although prior quasi-experimental studies have demonstrated that food or cash assistance can improve adherence to treatment or care, this study is the first to our knowledge to directly compare the 2 strategies against a comparison group in a randomized design. And it's also the first effectiveness study to our knowledge of conditional cash transfers for ART adherence in sub-Saharan Africa. So we find that both short-term cash and food transfers increase 6-month adherence and retention among food insecure ART treatment initiates compared to the standard of care. Many of these effects are maintained at 12 months, which is 6 months after the cash and food transfers have ended. And we know that the intervention's effect on adherence is most pronounced in the first 3 months of the program. Also, we see that these early effects on retention are nearly maintained at 12 months, which is 6 months after the incentives have ended, indicating durability of some of the intervention's effects. And this demonstrates the potential of early short-term interventions at the time of treatment initiation. So the potential value of short-term interventions when people are starting ART are illustrated by these data. This is Till Barninghausen's data that display the likelihood of being employed before and after HIV treatment initiation. And you can see that there is a sharp decline in labor force participation in the year before people start treatment, followed by a slow reentry into the workforce after treatment. So our interventions that are delivered at the time of treatment initiation may help to motivate people living with HIV infection to stay in care during this vulnerable time when people might have disengaged from the workforce and their household is vulnerable. So we also find that cash transfers were superior to food for some adherence outcomes. They were preferred by participants who were in the two intervention arms, and they were easily distributed through existing mobile money providers. And this suggests that cash might be a more promising intervention to consider for scale-up in many different settings. So I'd like to thank all of my collaborators shown here on this slide and funding from the NIH and PEPFAR, and I would like to welcome your questions. I'll also add, I didn't say this at the beginning, just that, Michelle, you've been such a nice thought partner throughout this study, and I'm really excited that you're involved in the next phase to look at some of the spillover effects. So we're delighted to have you on the team.
Thanks. I'm very happy to have had the chance to work on this as well. Great. Thanks a lot, Sandy. That was a very interesting presentation. There's something that just struck me as well now seeing your presentation this time, is that the attrition effect, so the effect you found on loss to follow-up, I have not come across that in previous studies where they've been able to show this effect, except I think there was one kind of observational study which was looking across sites and actually found that sites that did provide food support were more likely to have an impact on loss to, had lower attrition levels. So do you want to just comment on that? Because I think that's actually quite a big one, and in some of the modeling work and kind of economic modeling on this, that is definitely a big additional effect to be considered, especially given the high rates of mortality in those 6 months of after treatment initiation.
Absolutely. Am I able to go back and pull that slide up again? Yeah, so I'll say that we were actually quite surprised by this as well. Although sort of looking back over the literature on loss to follow-up, I think it's not all that surprising. It's fairly well established that loss or people disengaging from HIV care occurs fairly early after they start treatment, and you can see that really well here with that red line with that sort of pink-colored, salmon-colored confidence interval around it, that just really within the first few months people come in for their visits and then we lose them right away. So it does suggest that if you can keep them, given the way that the line sort of flattens out after 3 or 4 months, it does suggest that if you can intervene early, you could keep them in care for a longer period of time. So it's a really exciting finding. Of course, we can only follow them here up until 9 months, not 12, because to be defined as loss to follow-up, you have to have had 3 months since your last attended visit. So by definition, even though we follow people till 12, they can only be defined as loss to follow-up at 9. So it is relatively exciting, and I think it also suggests that you might not necessarily have to have an intervention that continues for months and months on end. You might actually just be able to intervene for 6 months or potentially even less just to help people come in during those first months. Now, there's a lot happening in those first months that we've thought about. So one is that in many parts of the world, including in Tanzania, when people start care, they've also relatively recently been diagnosed with HIV infection. And so they're sort of coming to terms with knowing that they're a person living with HIV, and that HIV status is being incorporated into their identity. And we know that there are time points in people's lives when their identity sort of changes and you incorporate new elements into your identity, and those are good times for intervention. So that could be part of this, right? This phenomenon that we observe early. In addition, there's some literature from the habit formation body of work that suggests that helping people establish habits and maybe nudging them in those first few months, that you could engage people in a pattern of behavior that then just sort of occurs afterwards, even after you get rid of that sort of extrinsic incentive. So those are two things that I think are definitely important elements here. I think also that mental health pathway that I highlighted is something that's incredibly important. There's a lot happening in people's lives at this time. It's possible that they're out of the workforce. There's some great data from the Fanta team that households can descend into distress very quickly around this time of treatment initiation, and so it is possible that we're helping prevent those households from descending farther into poverty by giving them this very short-term small incentive to get them through that vulnerable time. So I'm seeing a comment or a question from Jenny Carmichael. Thank you very much. Her question was, did the study include a cost-effectiveness component? And she's interested in the cost of the conditionality. Did monitoring adherence to transfer conditions incur additional costs? And I'm actually, Michelle, I'd like to bring you in on that question because Michelle has led that element of the study. I'll say from my end that we definitely found that monitoring the conditionality was associated with increased costs. We had to have a research team at the clinics monitoring when people came in and then determining whether those visits were eligible for transfers. So we set a predefined window, plus or minus 4 days from the scheduled visit, and if people came in for their visit within that 4-day window, they were eligible for a transfer. But certainly that required a lot of monitoring for our team, and it's made us think about the next iteration of this study and whether we would want to have such a strict conditionality or have more of a soft condition or an unconditional intervention. So I certainly would say that there's additional costs with that. And Michelle, I don't know if you want to comment on that as well.
Yeah, I think just to echo what you're saying, so yes, there is a cost effectiveness and a more general economic evaluation on this, and that monitoring definitely incurred additional, led to additional resource use, particularly for the research team. But I think just in terms of thinking through what that would mean for the effectiveness, if I remember correctly, the one study that did not find an impact of at least food assistance on adherence levels was the one in Mozambique, which actually was not conditional. So there is obviously something, it's worth testing and figuring out if there is a way to have an in-between, maybe a more softer type of conditionality and how that would impact on the effects. But just important to bear that in mind, I think. And also just to highlight that in Tanzania, the national cash transfer program is one of the few in Africa which does have a conditionality. Although it is implemented as a soft conditionality, it is quite keen to maintain some form of conditionality. So in terms of scaling up in Tanzania, you probably would have to maintain some form of conditionality there.
I would definitely agree. I'll also comment that I think by starting with this sort of stricter condition in this study, it definitely paved the way for us to explore different levels of conditionality all the way to something unconditional. I think one thing I'm interested in pursuing with this is I think it would be hard to have a completely unconditional transfer that's essentially just sent to people in the community where they don't have to have any interaction with the clinic. I think that would be hard just in terms of logistical challenges. But you could imagine a soft condition, and by that I mean that the condition is sort of implicit in how you deliver it, that if you come to the clinic at all, you would get your transfer in those first few months, where there's not this sort of strict monitoring of the window, but there's an implicit sort of nudge to come to the clinic because that's how you could get your transfer. So I think there's lots of exciting possibilities about how to implement this, and now it's our job to figure out how we could potentially do this in a way that actually makes sense. Yeah, so a great question here is share with us how sustainability is built into the food transfers and how you guard against dependency. So thank you for that question. So we intended for both of the interventions to actually be short-term. So the plan was not for people to be dependent on them for longer than 6 months. And this is also, just one research study focused on these two short-term interventions. So during the informed consent process, we made it very clear to people that the transfers were only for 6 months so that they could prepare ahead of time. And then as people actually approached their 4th month, 5th month, and 6th month of care, the team would sort of remind them, as a reminder, the transfer program is only for 6 months so that they could know in advance. So I will say that I think some people, though, were, kind of forgot that that's how it was going to work, or maybe had hopes that it would continue. But we did the absolute best job that we could so that people could understand that it was for 6 months. I think on average people received about 4 transfers, that they did miss a visit occasionally. So in terms of sustainability, I will say that this was something that we did not tackle in this research study, and I'd actually love your thoughts about this. I think that my sense was that something like the food baskets, they were very expensive to have to deal with the extra costs, including procuring the food, making sure that it was stored in a way that would protect the food and it was secure, and then just having to have separate staff members who would distribute the food, so there was additional costs with that. So I actually don't see that as a highly sustainable model. However, I think that there was definitely interest in could that be an effective way to mitigate food insecurity, and so that was why we selected it as one of our interventions. I think that cash transfers have more potential to become a sustainable intervention, especially in settings like Tanzania, where there is a government-run cash transfer program. So one idea is that potentially, these data could be shared with the TASF program to maybe urge them to expand their criteria for the beneficiaries to maybe include AIDS-affected households. That's very speculative, but it is definitely one thing that we've thought about, because ultimately we want to understand what is the sustainable version of these interventions. But I would certainly welcome your thoughts as well, and others on the call.
I was just wondering, there's a lot of concern at the moment about the big loss of patients in the step of the linkage to care step. So essentially, once people are diagnosed, actually getting them started on ART seems to be where we're losing a lot of people. And there is some thinking about whether we can be using incentives, these types of incentives like cash or even food, as a way of nudging people in and linking them, getting them to have that linkage to care. What are your thoughts on that based on this, on your experience with the study, and have you maybe even through the study or through some of the qualitative work noticed if your intervention did work in that way once people were hearing about the trial? Very good question. And actually right now our team is working on a systematic review of behavioral economics approaches for linkage and also adherence. So we've definitely looked at a few studies that have looked at incentives for linkage. I will say I have slightly mixed feelings about it. So certainly I think that the evidence is fairly overwhelming that incentives work, and they work in particularly well for short-term or one-off behaviors like linkage to care. But interestingly, I have a study here in California with young MSM, and it's an incentive study, and we actually decided not to provide incentives for linkage to care because we felt like there were some ethical or issues that we couldn't quite contend with to our satisfaction. And most of it had to do with some of the issues I mentioned earlier, which are when people are first diagnosed, it's sort of an overwhelmingly emotional, sort of life-changing day, and it feels in some ways sort of awkward or inappropriate to then be offering them cash to go to care. And I know it can be done in a very appropriate way, but in our case, we just couldn't quite get our heads around how to do that. And I've done some previous work where people, the suicide ideation is really high around that time, and it just felt sort of strange to me. But I will say I've seen some data on supply side incentives. So those are incentives that are targeted toward HIV counselors or to health facility staff,
where you incentivize them to help make the warm handoff to care. And I think those have a lot of promise. Now, certainly you'd have to monitor carefully to make sure there were no harms that you would create by doing that. But I think it's actually a really promising idea to incentivize some of the healthcare workers to make sure that people engage in care and actually get to that first visit, and providing support and encouragement to health facility staff to help make those connections as seamless as possible. So that's where I actually see quite a bit of promise on that. Do you have particular opinions?
Not really. I'm still, I suppose, just still curious to see more data come out on that. But some people working more in kind of nutrition and food as well have been there have been thoughts of how to do that and build in these kind of food baskets as an incentive to link to care. And I think we'll probably hear a lot more interest in that, given that for example, a lot of at least the test and treat trial in South Africa seems to show that was the big hurdle in the effectiveness of the test and treat approach. So I would imagine that incentives might become more sought after for that. But just curious to see what the evidence is going to say.
So I just received another question. So did the qualitative include anyone lost to treatment and explore why they dropped out? Oh, this is a great question, and unfortunately we did not, but it's a great idea. Excuse me. So our qualitative study was focused mostly on the use of the interventions. So when we first started the study 2 years ago, there was a lot of concern about adverse effects of the incentives, and particularly were people going to use cash for alcohol or for to purchase sex, or would they actually use it for things that we deemed as good things to use the cash for. And we were also very concerned with whether there was any stigma associated with picking up the food basket and transferring the food basket home. So our main concerns for the qualitative study were just to make sure that we had fidelity to our intervention plan, and also that there weren't any unintended adverse effects. And we did, to be perfectly honest, we didn't anticipate this effect on loss of follow-up. So we conducted the qualitative study at the end of the intervention period, so at that 6-month mark, with people who had received cash and food. And we purposefully selected people who had received at least a few cash and food baskets, either cash transfers or a few food baskets, so that we could talk to them about the experience of receiving the transfer, and also how they used the transfer. So we were really interested in the decision-making process, the sort of inter-household bargaining process, who people told, so all of that. So we did not interview people who were lost to follow-up. But it is such a great idea. Now that I'm looking at this Kaplan-Meier plot, it makes me think that we had a lot more to explore in that regard, to understand why people were dropping out of care. So excellent question, and I wish I had more data on it. But unfortunately, it's not something we anticipated in the middle of the trial.
Thanks, Sandy. I'm just wondering, there's an indirect question here of maybe some reflections on what the implications of this are for practice and programming. Essentially, you mentioned already that Tanzania has a government-run national cash transfer program, and that this might be something for that program to consider, kind of adding the HIV-affected households to the eligible beneficiaries. Do you have any other thoughts on kind of what this means for those of the people on the line who are programmers or policy makers, and also maybe reflect a bit on how transferable some of this might be to other settings?
Very good. I'd be happy to reflect a bit on that. I think in terms of the programs, I mean, as I mentioned earlier, we're definitely thinking about we want to take this evidence. This was a very tightly controlled research study, but obviously, as a public health professional, my goal is not necessarily to do just one study and sort of walk away. We definitely want to think about what do we do with these data. So we want to think more about the implementation model, of course, and that maybe could be adopted by health facilities. But in addition, think about larger possibilities, and that includes things like TACIF and integration with existing government-run cash transfer programs that are already doing this and that already have the infrastructure to deliver cash transfers on very large scales. So it probably doesn't make sense for HIV providers to be thinking about this if there's already an existing program in place. So I think integrating with existing anti-poverty programs I think makes a lot of sense. But it would be our job to figure out whether there needs to be conditions and how it would be implemented, how it would be integrated with clinical care, if at all. So I think those are the things that we would need to think about. But I think at a broader level, I think just looking again at this curve of the Kaplan-Meier curve of loss to follow-up, it really does suggest that anything that we do in those first 3 months can be critical to keep people in care for the long term. So here, we're looking at two very specific interventions, cash or food, but it's very possible that other interventions or other simple nudges during that time could have longer-term effects. It seems as if, not just these data, but a broader body of data suggests that this is a hurdle for people. These first few months are very difficult, and that the things we can do to ease that transition, to make them feel included and that they have social support, and to recognize and to the best of our ability help them overcome any economic constraints, that those things could have longer-term benefits. So I think maybe taking better care of our ART initiates, maybe that's something that could be implemented at a programmatic level in a variety of different ways. So in this part of Tanzania, it's very food insecure, and so our approaches were through sort of an economic lens, but it's possible in other parts of the world or in other regions of Tanzania that different kinds of support mechanisms are needed in those first few months, and I think that could be something that is context-specific. But obviously the overlap of food insecurity and poverty with the HIV epidemic applies to many, many settings, and so helping people economically during this vulnerable time, I think, is something that is not just specific to this western part of Tanzania, but specific to larger swaths of areas that have generalized HIV epidemics. And I'd also welcome other people's thoughts on that as well.
Thank you. Yes. Does anyone else have anything they want to bring in or add to this discussion at this point? I think we've lost a couple of people from Tanzania, because I was about to ask the Tanzanians from Strive and just Tanzanians on the line what they thought of this and its scalability in Tanzania, but I don't see their names anymore. So if no one else has any questions, Sandy, I might give you a chance to just share any final thoughts you might have, or maybe the further, or let us know what's coming up in this based on this study. Any ongoing work, further analyses that you're doing, so that we can all watch the space, and then after that we'll just close the session, I think.
Yeah, I'd be happy to. So so these are the sort of main analysis that I've just presented to you today. And these data are under review in a journal. We have two other papers that are actually going to be submitted very soon. One of them is the Qualitative study, and it seems like there's definitely some interest in that, and that's led by Dr. Nancy Seiske, who was a former PhD student in our group. And she, I think, adds quite a bit to the literature on how people use transfers, and also confirms that people don't use transfers in these settings for alcohol and tobacco and purchasing sex, at least not from what they told us. We have another paper that actually looks at intrinsic motivation. So there's a theory that extrinsic motivation or extrinsic incentives, things like cash or food, actually what people say is that they crowd out your intrinsic motivation to engage in a health behavior, such that when you remove the incentives, you're actually less motivated than you were before to engage in the behavior. So in other words, incentives actually do harm in the long run. And so our analysis of intrinsic motivation, so we've asked people in the survey, why they're coming for their ART, what is their their sort of belief around why they're taking ART, how motivated they are, and is that motivation related to the incentive. We actually find that people's intrinsic motivation to be adherent to ART actually increases over time in all of the groups, and that there's no difference between groups even at 12 months once the incentives are over. So we actually find no evidence to support that crowding out hypothesis, or in other words, that incentives do harm. If anything, we find that people become more intrinsically motivated to adhere over time in the overall study population. And this might be because people are feeling better. You know, they're starting ART, they're gaining weight, their appetite is coming back, they might be returning to work. So our hypothesis is that in this particular setting, providing incentives is actually not doing any harm because they become more and more intrinsically motivated to be adherent over time, given those dramatic benefits of ART. So those two papers, you can look for those, probably once they're out in a few months. Michelle Rame is leading the economic analysis, and we are very grateful to her for all of her work and her participation, and for actually helping us think through this from a cost lens, which has been a fantastic learning exercise for me. And then the last project that we're doing, at least right at this moment with these data, are looking at the effects of the interventions on food insecurity and nutritional outcomes. You'll notice that I did not present those today. And the reason is we actually have an interesting methodological issue, such that, which is actually shown here on this slide, which is that we have differential loss to follow-up in our three groups. And so if we only look at food insecurity among people who are retained, we have a sort of a missing data problem. And so we have a PhD student in epidemiology and biostatistics who will be looking at the effect of the interventions on food insecurity, but using some novel methods to account for this differential loss to follow-up. So that's the other paper that is underway. I will just highlight that that's sort of the work that we're leading at UC Berkeley, but clearly there are many people working in this area, and I'll just highlight, a couple of people, including Sherry Weiser, who's at UCSF, who has done some interesting work in this space. She's looking at livelihood interventions, and I think we're all interested in the same sort of different pieces of the same causal pathway, which are can economic or structural interventions improve HIV-related outcomes? And so she has some interesting work in her study called Shamba Maisha, and the second phase of that right now, where she's providing agricultural inputs and agricultural assets to farmers who are living with HIV infection. So she certainly has some interesting work in this area that I think is quite complementary in terms of the approach. And then there's, of course, the Food and Nutrition Technical Working Group at PEPFAR and Fanta, and that there's many groups who are interested in these kinds of interventions. And I think they're getting growing attention as there's sort of increasing recognition of the importance of people's economic situation and their livelihoods on HIV care. Thank you very much.
Brilliant. Thanks so much, Sandy. Thanks for summarizing also everything else that's going on in this area and pointing people towards those extremely useful studies and resources and key experts. So I think we're going to wrap up. Thanks again to all of you for joining us from all over the world. We hope you found this useful. Thank you so much, Sandy, for doing this and for sharing these extremely interesting results, which are still quite new. So I'm happy we were able to share them to all these people that were interested.